Good afternoon, everybody. Today we'll talk about the ECG in acute ischemia and acute myocardial infarction. ECG plays a very significant role in the management of acute ischemia. In fact, no other investigation is as important as ECG when it comes to acute ischemic heart disease. None of the other tests will give us as much information as an ECG gives. Fundamentally, today most of us do ECGs on a day-to-day basis to either confirm or rule out an ischemic heart disease when a patient comes with a chest pain. When we talk about the ischemic heart disease, we are interested to know whether the patient has an ischemia or infarction. Infarction is where the muscle is getting damaged, which we call commonly as an MI. Ischemia is where there is no muscle damage, but the patient's blood supply to the myocardium is critically compromised. So acute coronary syndromes we divide into three parts. Unstable angina, where there are only ECG changes in the chest pain, no rise of the enzymes. Non-ST elevation MI is where there is chest pain, where there are no ST elevations in ECG, but the troponins are positive. And the third category is ST elevation MI or STEMI, which we commonly talk of as a myocardial infarction. And it is associated with the chest pain, ST elevations and the ECG, and the troponins when done are also going to be positive, but need not always be positive, especially if the patient has presented to you early in the course of the disease. So whenever a patient comes with a chest pain suggestive of an ischemic origin, the ECG becomes the pivotal, and ECG and the chest pain in combination will give us a diagnosis in most of the patients. What do you need to look at when we talk about the ischemia or infarction? We need to focus mainly on the ST segment and the T wave inversions. So when we talk about the ischemia, there will be ST depressions along with the T wave inversions. And there are different kinds of ST depressions which you will master by looking at the different ECGs. There's what's called as upsloping ST depressions. These are very non-specific and may or may not be associated with ischemic heart disease, but to be considered significant if you also see an associated history suggestive of a ischemic pain. Then we have got what is called as horizontal ST depressions, which is most likely to be associated with ischemia, whereas there's third variety which is called downsloping, which is almost always associated with the ischemia to the myocardium. Then when we talk about the infarction, we look at the ST elevation. To characterize more, we talk about ST elevations after the 80 milliseconds from the J point, and then the ST elevations, that is convex upwards. The STT changes progress over time. When initially seen, there can be very minor ST elevations without much of the changes in the T wave. After some time, the T wave starts becoming very tall, what we describe as a hyperacute T waves, and subsequently the height of ST elevation goes up, T wave merges with the ST segment. You will not see a separate ST segment and the T waves, and after some time the ST starts settling down, T starts flattening and can become inverted. Q waves is also an indicator of a myocardial infarction, but it generally tells us that there has been some time since an infarct. It's not very significant in diagnosing the MI in the acute situation. We generally don't give too much of the weightage to the presence and the absence of the Q waves. And unlike previously, where the Q waves were denied the benefit of thrombolytic therapy, today's world there's no much difference between the treating the patient with or without the Q waves. Also, when we have an ECG changes, the particular lead set of leads, it points towards the certain artery of involvement. We generally talk about involvement of LAD, LCX, or the right coronary artery and its branches, and these are very specific, more in cases of ST elevation MI than in cases of unstable angina or non-ST elevation M. So to make a diagnosis of MI, you need to have an ST elevation in at least two contiguous leads, that is 2-3 AVF, V1 to V6, 1 AVL in their different combination. At least two leads should have a 1 mm of ST elevation in the precordial leads or the 2 mm of ST elevation in the chest leads.